I want you to do something before this video is 30 seconds old. Place your right hand flat on your abdomen, just below your rib cage on the right side. Press in gently and hold for 3 seconds. Not hard enough to cause sharp pain, just firm, sustained pressure. Now release and press again slightly lower, moving down toward your hip. What did you feel? If you felt nothing, a soft give with no discomfort, that is one result. If you felt a dull ache, a tenderness, a pressure that was not quite pain but was clearly something, that is a different result entirely. And if you felt a sensation that made you want to pull your hand away, that is the result I want to talk to you about right now. Because your liver has been trying to get your attention, and until this moment, you may not have known how to listen. I am Dr. David Miller. I have been practicing medicine for 15 years, and I built this channel on one principle. The healthcare system is designed to treat you after something breaks. It is not designed to help you understand what your body is telling you before that point. That is what I do here. Subscribe to Dr. Miller right now and hit that like button. We are working toward a community of people who understand their own bodies well enough to act before a diagnosis finds them. Every subscriber makes this channel more visible to someone who needs it. The liver is the most underestimated organ in the human body. It performs over 500 distinct biological functions. It filters every drop of blood that passes through the digestive system before that blood reaches the rest of the body. It produces bile for fat digestion, manufactures clotting factors, stores glucose, metabolizes medications, neutralizes alcohol and environmental toxins, produces the proteins that carry hormones through the bloodstream, and regulates cholesterol synthesis. It is the body's chemical processing plant, its central filter, and one of its primary hormonal regulators, all simultaneously. And here is what makes it particularly dangerous from a clinical standpoint. It has almost no pain receptors of its own. The liver itself cannot hurt. What you feel when liver disease produces discomfort is the pressure of an enlarged or inflamed liver against the capsule of tissue that surrounds it, called Glisson's capsule, which does have nerve endings, or the referred sensation of pressure against adjacent structures. This means that by the time you feel anything at all in the liver region, the process that created that sensation has usually been operating silently for a significant period of time. Let me tell you about a patient I will call Victor. He was 58 years old. He came to see me for what he thought was a digestive problem. He had been experiencing a persistent heaviness in his upper right abdomen for several months, not a sharp pain, nothing that stopped him from working or sleeping, just a dull, consistent sense of fullness and mild pressure that would not go away. He had taken antacids. He had tried avoiding certain foods. Nothing changed. His previous doctor had attributed it to acid reflux and given him a proton pump inhibitor, a stomach acid suppressor. Victor had taken it for 2 months with no effect and had come to me because something told him the answer was not in his stomach. When I pressed on Victor's abdomen in the region I described at the start of this video, I could feel the edge of his liver extending approximately 2 centimeters below the lower margin of his ribcage. In a healthy adult, the liver sits entirely behind the ribcage. You should not be able to feel its edge below the ribs. When you can, when the liver has expanded enough that its lower border has descended into palpable territory, that is called hepatomegaly, enlarged liver. And while hepatomegaly has multiple causes, ranging from benign to life-threatening, none of them are something to observe and wait on without investigation. Victor's blood work told a story that his stomach acid suppressor had been entirely irrelevant to. His liver enzymes were elevated. Specifically his ALT, which is alanine aminotransferase, an enzyme released into the bloodstream when liver cells are damaged or inflamed, was 3 times the upper limit of normal. His GGT, gamma-glutamyl-transferase, an enzyme particularly sensitive to liver stress from fat accumulation and alcohol, was also significantly elevated. His fasting insulin was high, indicating significant insulin resistance, and his ultrasound showed a liver that was diffusely echogenic, brighter than normal on imaging, the characteristic appearance of a liver infiltrated with fat. Victor had non-alcoholic fatty liver disease. He drank rarely and moderately. His liver was not damaged by alcohol. It was damaged by decades of metabolic stress that had never been caught, measured, or addressed because nobody had pressed on his abdomen, nobody had ordered a GGT alongside his standard liver panel, and nobody had connected his slightly elevated fasting glucose over the past 4 years to what was accumulating in the tissue of his liver. I want to spend this video explaining exactly what was happening in Victor's liver, how it got there, what the warning signs are that most people are walking around with right now without recognizing them, and what the evidence actually says about reversing it, because the answer to that last question is more hopeful than most people expect. Your liver and fat have a relationship that becomes dangerous when it tips out of balance. A small amount of fat in the liver is normal and physiologically unremarkable. Problems begin when fat accumulates beyond approximately 5% of the liver's total weight. At that threshold, the condition is called hepatic steatosis, or fatty liver. In the early stages, it produces no symptoms and no pain. Liver enzymes may be mildly elevated or entirely normal. The liver is enlarged but not dramatically so. Most people at this stage have no idea anything is happening. The mechanism by which fat accumulates in the liver is directly connected to insulin resistance, and understanding this connection is the key to understanding why fatty liver disease has become the most common liver condition in the developed world, affecting an estimated 25 to 30% of adults globally, with rates significantly higher in people over 50. When you eat carbohydrates, they are broken down into glucose and released into the bloodstream. The pancreas releases insulin in response, which signals cells throughout the body to absorb that glucose and use it for energy. In a healthy metabolic state, this process is efficient. Glucose is cleared from the blood, insulin levels return to baseline, and the system resets. But in a state of insulin resistance, which develops gradually over years in response to consistently elevated blood sugar, high refined carbohydrate intake, sedentary behavior, and chronic low-grade inflammation, the body's cells stop responding efficiently to insulin's signal. The pancreas compensates by producing more insulin. Elevated insulin levels signal the liver to convert the excess glucose that is not being taken up by resistant cells into fat, specifically into triglycerides, which are then stored directly in the liver tissue. The liver becomes a holding facility for the metabolic overflow of a system that has lost its normal efficiency. And it does this silently, without pain, without any symptom you can feel, until the accumulation has reached a significant level and the liver has begun to expand against its capsule. Subscribe to Dr. Miller and hit like. What I just described, the insulin resistance to hepatic fat accumulation pathway, is the central mechanism of the most prevalent liver disease in the world, and it is almost never explained in those terms in a standard clinic visit. The conversation is usually limited to losing some weight and watching your diet, without the physiological context that makes those recommendations genuinely actionable. This channel exists to provide that context. Hit subscribe. It costs nothing, and it means the next person searching for answers finds real information instead of generic advice. Beyond simple fat accumulation, a significant proportion of people with fatty liver progress to a more advanced stage called non-alcoholic steatohepatitis, abbreviated NASH, in which the fat accumulation is accompanied by active inflammation and the beginning of cellular damage in the liver tissue. At this stage, liver enzymes rise more significantly. The liver begins to show early signs of fibrosis, which is the formation of scar-like tissue in response to chronic inflammation, and the risk of progression to cirrhosis, the replacement of functional liver tissue with non-functional scar tissue, becomes real and measurable. The transition from simple fatty liver to NASH to fibrosis to cirrhosis does not happen quickly. It takes years, sometimes decades, but it is not inevitable, and the stage at which intervention occurs determines the outcome almost completely. The warning signs I want you to know, beyond the pressure test I asked you to perform at the start of this video, are the ones that most people either ignore or attribute to something else entirely. Persistent fatigue that is disproportionate to your activity level and does not resolve with rest is one of the earliest functional signs of liver stress. The liver is involved in energy metabolism at a fundamental level, converting stored glycogen to glucose, clearing the byproducts of cellular metabolism, and maintaining the blood chemistry that the brain and muscles depend on for normal function. When the liver is inflamed and its cellular machinery is compromised by fat accumulation, energy metabolism becomes less efficient throughout the body. The fatigue this produces is qualitatively different from ordinary tiredness. It has a heaviness to it, a resistance, a sense of running on a lower charge that does not respond to sleep the way normal tiredness does. Discomfort or fullness in the upper right abdomen, which I have already described, is the second sign. Even when it is mild enough to be easily rationalized as digestive bloating or postural discomfort, persistent right upper quadrant heaviness in a person over 50 deserves investigation rather than antacids. Elevated triglycerides on a standard lipid panel is the third sign, and this is the one most frequently overlooked because the conversation about the lipid panel almost always focuses on LDL cholesterol. Triglycerides are the form in which the liver packages excess fat for storage and circulation. When the liver is in fat accumulation mode, circulating triglycerides rise. A fasting triglyceride level above 150 milligrams per deciliter is a signal worth investigating in the context of liver health, particularly when accompanied by low HDL cholesterol, which is the characteristic lipid pattern of insulin resistance and hepatic fat accumulation. Elevated fasting blood sugar or insulin is the fourth sign. Because fatty liver and insulin resistance are so tightly coupled, an elevated fasting glucose, even in the pre-diabetic range of 100 to 125 milligrams per deciliter, should prompt a liver evaluation in anyone over 50. And specifically, a fasting insulin measurement, which is not part of the standard blood panel and must be specifically requested, is one of the most informative early markers of the metabolic state that drives liver fat accumulation. Elevated fasting insulin in the presence of normal fasting glucose means the pancreas is working significantly harder than it should to maintain normal blood sugar, which means insulin resistance is already present and the liver is already under metabolic stress. The fifth sign is one that appears on the skin rather than inside the body, and it is the one that most patients find most surprising when I point it out. Small collections of fat deposits, yellowish, slightly raised plaques that appear around the eyes or along the tendons of the hands, called xanthelasma and xanthomas respectively, are direct external markers of severe lipid dysregulation. They are deposits of cholesterol-laden cells in the skin and tendons, and they appear when lipid metabolism is significantly compromised. They are not cosmetic findings, they are diagnostic ones. Now I want to give you the protocol because the most clinically important fact about fatty liver disease is this. At the stage of simple steatosis and even at the stage of early NASH, the liver retains a remarkable capacity for regeneration. The liver is the only solid organ in the human body that can regenerate lost functional tissue. Remove 60% of a healthy liver and it will grow back to near normal size and function within weeks. This regenerative capacity, while it diminishes with advancing disease and age, means that early intervention produces genuine tissue-level recovery, not merely symptom management. The first and most evidence-supported intervention is the reduction of dietary refined carbohydrates and added sugars, not the elimination of carbohydrates entirely, which creates its own metabolic stress. The targeted reduction of the specific carbohydrate forms that drive the greatest insulin response and the greatest hepatic fat accumulation. These are added sugars, including fructose specifically, which is metabolized almost exclusively in the liver and is converted to fat at a rate far higher than glucose. Sugary beverages, fruit juices, processed snack foods, and anything containing high fructose corn syrup are the primary targets. Clinical trials consistently show that reducing fructose intake produces measurable reductions in liver fat within 8 to 12 weeks, confirmed by imaging. The mechanism is direct. Less fructose reaching the liver means less substrate for the fat synthesis pathway that has been running in overdrive. The second intervention is consistent physical activity, with a specificity that most general recommendations miss. The type of exercise that produces the greatest reduction in hepatic fat is not high-intensity training. It is consistent, moderate-intensity aerobic exercise, specifically walking, cycling, or swimming at a pace that elevates the heart rate to between 60 and 70% of maximum, sustained for at least 30 minutes, 5 days per week. At this intensity, the body preferentially mobilizes stored fat for fuel, including the fat deposited in the liver. Studies using liver imaging to measure fat content before and after exercise interventions consistently show significant reductions in hepatic fat with this protocol, independent of changes in body weight. You do not have to lose significant weight to reduce liver fat. You have to move consistently at the right intensity. The third intervention is coffee, and I say this not as a lifestyle suggestion, but as a clinically documented hepatoprotective intervention with a body of evidence behind it that I find genuinely remarkable. Multiple large-scale epidemiological studies and several controlled trials have established that regular coffee consumption, 2 to 3 cups per day of filtered coffee without added sugar, is associated with significantly lower rates of liver fibrosis progression, lower liver enzyme levels, and lower rates of progression from fatty liver to NASH in people with established hepatic steatosis. The mechanism is not fully understood, but appears to involve compounds in coffee that reduce oxidative stress in liver cells and suppress the inflammatory pathways that drive fibrosis. This is not a cure, it is a meaningful adjunct. In a person already making dietary and exercise changes, consistent coffee consumption adds a layer of hepatoprotection that requires nothing more than a habit most people already have, adjusted for sugar content. The fourth intervention is the specific supplement that has the most rigorous evidence for reducing liver inflammation in NASH. Vitamin E, at a dose of 800 international units per day of natural alpha-tocopherol, has been shown in controlled clinical trials to produce significant reductions in liver inflammation markers and improvements in liver biopsy findings in people with non-alcoholic steatohepatitis who do not have diabetes. This is not a trivial finding. These are biopsy-confirmed histological improvements, meaning the tissue itself looks better under a microscope after treatment. Vitamin E is not appropriate for everyone and should be discussed with a physician before starting, particularly in people with cardiovascular risk factors. But for the appropriate patient, it represents one of the most evidence-backed nutritional interventions in liver medicine. How old are you? Write your age in the comments right now. I want to see the age distribution watching this channel because it determines what I focus on next. If the majority of you are in your 50s and early 60s, I want to go deeper on the reversibility window, the specific stage at which intervention produces the most complete tissue recovery. If many of you are in your late 60s and 70s, I want to address the question of what the evidence says about liver regeneration at that stage, because the answer is more encouraging than most people have been led to believe. Victor came back to see me 6 months after our first appointment. He had removed added sugars and refined carbohydrates from his diet consistently. He had begun walking 40 minutes every morning. His fasting insulin had dropped from markedly elevated to near normal range. His ALT had normalized. His GGT was still mildly elevated but trending downward. His repeat ultrasound showed a liver that was less echogenic than 6 months earlier, meaning the fat content had visibly reduced on imaging. The edge of his liver was no longer palpable below his ribcage. He told me that the heaviness he had felt in his right side for the better part of a year was gone. Not improved. Gone. His liver had been sending him a signal for months. Once he understood what the signal meant and addressed what was causing it, the organ responded precisely as the biology predicts it should. Your liver is one of the most resilient organs in your body, but resilience is not the same as invulnerability. It will absorb an enormous amount of metabolic stress silently for years before it begins to signal distress in ways you can feel. When it does signal, the signal deserves to be taken seriously, investigated properly, and addressed at the level of cause rather than symptom. Press on your abdomen again. If that tenderness is there, now you know what it may mean, and now you know what to do. I am Dr. David Miller, and I have spent 15 years watching patients treat their liver symptoms with antacids, digestive enzymes, and dietary adjustments aimed at the stomach while the actual process continued uninterrupted in the organ just above it. The liver does not ask for much. It asks that you understand what is driving it into overload and remove that burden before the damage becomes irreversible. Subscribe to Dr. Miller. Hit the like button. Share this with someone who has been told their slightly elevated liver enzymes are nothing to worry about. Slightly elevated is a signal? It is not reassurance. The healthcare system profits from managing your condition after it becomes serious. I profit from you catching it before that point. Subscribe if that difference matters to you. This content is educational in nature and does not constitute personalized medical advice. If you are experiencing abdominal discomfort or have concerns about your liver health, please speak with your physician about appropriate evaluation and testing. The mechanisms and interventions discussed here should be explored in partnership with a qualified healthcare provider who knows your individual medical history,